Okay, I think we will go ahead and get started for the sake of time as more folks enter the webinar. Welcome all to today's webinar on health department activities for the prevention of congenital syphilis and perinatal HIV. This webinar is a collaboration between NCSD, NACCHO, and NASTAD. Just some housekeeping items before we get started. We ask that everyone please mute themselves so that all presentations can be heard. Also, this webinar is being interpreted into Spanish and English. At the bottom of your screen, you should see an option for interpretation, which is shaped like a globe next to your share screen button. Please click on that and select the language that you would like to hear this webinar in, English or Spanish. And that will allow you to hear all of the presentations in your preferred language. Next slide, please. We will be sharing the recording from today's webinar as well as the slides. Our presentations today are from 3 health departments: the Puerto Rico Health Department, New York City, and Miami-Dade County. And we will have time for questions at the end. So we ask that everyone stay on mute until the presentations are done. When we have Q&A, if you would like to ask a question, please use the reaction button to raise your hand and we will call on folks. We'll do our best to get to as many questions as we can. For those questions we're not able to get to, we ask that you please email the presenter directly. We will ask them to put their email addresses in the chat later on. And then after Q&A, we'll go through the compendium and share information on how you can submit your activities to the compendium. And then when you exit out of this webinar, you will see a really quick evaluation. We would love your feedback. So please do fill that out as you exit the webinar. So I'm going to pass it on now to our first presenter of the day from the Puerto Rico Health Department. So Magda, over to you.
Thank you. Buenas tardes y saludos. Mi nombre es Magda Ayala Bonilla. Soy la coordinadora perinatal de la División de Prevención de ETS, VIH y hepatitis virales del Departamento de Salud de Puerto Rico. Agradezco a los organizadores de este evento por la invitación y la oportunidad de participar en este seminario. Les pido disculpas por mi tono de voz, ya que me encuentro un poco enferma. Comenzamos. Próxima, por favor.
So, next slide, please. Let's start with our objectives of this presentation. We're going to present the scope of the measures and the legal framework related to HIV and STD perinatal prevention. We're going to look at the historic context of the elimination of perinatal HIV and PR. Then we're going to look at the epidemiologic data of infants exposed to HIV, discuss the strategies and impact for perinatal prevention in priority population, introduce the Prevention of Perinatal Infections Board, and illustrate the various collaborative efforts to strengthen surveillance. Next slide, please. Here's the legal framework with regards to the perinatal section of the division. I'm going to sum it up because we don't have much time. It's important to mention Law 81 of 1983, which is a law for prevention and treatment of STDs in Puerto Rico. I also mentioned the Administrative Order 307 of 2013, where physicians must comply in ordering HIV tests to all pregnant women in the first and third semesters of pregnancy. And lastly, in 2008, we implemented the public policy regarding rapid HIV tests in delivery rooms in Puerto Rico. Next slide, please. And this is the historical context. And I'm also going to sum it up briefly. 1988 was the first HIV/AIDS proposal for the pediatric AIDS program, and it was approved. And at the same time, the Woman, Infant, and Transmission Study was created. In 94, the Puerto Rico Department of Health offered AZT to all pregnant women living with HIV during prenatal care. 2008 is when the public policy for the utilization of rapid HIV tests was implemented in delivery rooms in Puerto Rico. In 2016 was the approval of Law 45, approving HIV testing as part of the routine testing of any medical evaluation for the entire population. Next slide, please. In this first graph, we have the distribution of infants exposed to perinatal HIV by year of birth and that have been reported to the surveillance office. The rate from 2005 to 2022, if we see that the number of infants exposed has been reduced over the years, this is comparable to the reduce in the birth rate in the island. We can also observe that in 2011, there have been vertical transmission of HIV, and this is evidence of the impact of the measures and strategies that have been implemented over the course of the years and are still practiced here in Puerto Rico. Next slide, please. This second graph, we can observe the efforts for all people know their HIV status and how it's been of great impact in the reduction of vertical transmission of HIV. And here, most people knew their status during pregnancy. Most pregnant women knew their status. And after 2006, we have a higher percentage of pregnant women who knew their HIV status prior to getting pregnant. Next slide, please. Here, we look at some of the strategies of perinatal reduction. Among these are access to clinical research, comprehensive care. We talk about comprehensive care. It's very important to mention medical services, psychological services, social services, as well as providing education and support for patients and coordinate intervention by a multidisciplinary team before, during, and after birth, and the policy making. Other strategy was early identification of women who were pregnant with HIV and prenatal screening for HIV. And lastly, treatment for pregnant women during the prenatal process and postnatal treatment. Next slide, please. And what has been the impact of these strategies to reduce vertical transmission of HIV? As I mentioned earlier, in Puerto Rico, the vertical transmission rate has been 0 since 2011. Since 2006, over 69% of women who were pregnant living with HIV knew of their diagnosis before pregnancy. Since 2008, over 80% of pregnant women living with HIV each year received ART, antiretroviral treatment during pregnancy. It's worth pointing out that these strategies, the impact, have been the result of collaboration between researchers, the Puerto Rico Department of Health, and the medical community at large. Among these, Dr. Zorrillo, Dr. Feu, to implement an intervention for prevention at the public health level that has been successful and sustainable. Next slide, please. Among the current efforts for perinatal prevention in women who are pregnant and of reproductive age, we're developing an administrative order that is integrated to provide screening tests for syphilis, HIV, and hepatitis B and C during pregnancy to all as part of prenatal care. And an action committee was created for discussion and analysis of the management of these cases. And we also have a comprehensive analysis of case mortality, which is a passive transfer. And we also developed a confidential report form for service providers so we can compile data. Next slide, please. Another of the current efforts underway or have been developed, providers have developed an OBGYN directory that's specialized and is available in the STV, HIV, VHTB prevention division. This directory is constantly being updated. A total of 247 providers were contacted to receive orientation about public policies regarding HIV and STI screening during prenatal care. And we provide individualized technical assistance for providers. Either they don't follow recommendations of the CDC, and they're then referred to the perinatal coordinator. And then they contact the doctor to discuss the situation and provide orientation. Afterwards, an email is sent as a review about what was discussed together with reference material. And the hospitals, we developed a directory of all hospitals, is available to the public and is divided in two sections: delivery rooms and information management. With the contact at all hospitals with delivery room were contacted to discuss implementation of rapid HIV testing in delivery rooms and to review the monthly statistical report, which is received in the division. And we also, medical records are requested for cases of congenital syphilis and HIV. And for this, we drafted a formal letter of the importance of careful review of the medical file in order to meet confidentiality criteria. Next slide, please. This slide shows in the map of Puerto Rico, there's 56 hospitals. Of these, 29, only 29 have delivery rooms, which is 51%, a little over half, to service the entire population. The delivery rooms is due to many factors that affect service, such as the reduction of the birth rate and loss of doctors and other factors. Next slide, please. This is the monthly statistical report sheet, which is received from the hospitals. The perinatal coordinator monitors this systematically and with the delivery room supervisor. Hospitals contact the perinatal coordinator directly to report the birth of an HIV-exposed baby or baby born to a mother with a syphilis diagnosis. In 2022, the most common reason for HIV testing and delivery were that received prenatal care but did not have third trimester HIV test result. And as a second alternative, they received limited or no prenatal care. Most testing was conducted for women between the age of 19 and 24 and 25 to 34. In 2022 to date, we have 2 preliminary positive results per year. The perinatal coordinator provides follow-up with the hospital and clients to link them to the services and treatment. Next slide, please. This is the monitoring of public policy. We can see that at the end of 2022 and as of this year, 28 of the hospitals reported HIV testing, which is 97% reporting rate. In 2022, 11 of 29 were reporting. This might have been due to the fact that the person that preceded me in the division had retired and there was a vacancy for about 2 years. Once I started in November of 2022, that's when we started to reinforce compliance with public policy. So we have a 41% increase in reports. By 2022, 774 pregnant women were screened for HIV at time of birth, at time of delivery. Next slide, please. Here we have the Board for the Prevention of Perinatal Infection. This started in 2020 during the COVID-19 pandemic. At that time, it was strictly for congenital syphilis case review. This is a multidisciplinary team of various health professionals, government and academic institutes. Efforts are geared to addressing the situation of perinatal cases by conducting a case analysis, identifying missed opportunities and proposing solutions to address these gaps, developing a work plan, and preparing a report with recommendations to be submitted to the government. As of 2022, the integration of perinatal HIV and viral hepatitis was implemented. By December 22, the committee changed its name to the Board for Prevention of Perinatal Infections. Next slide, please. And here, to conclude, these are the collaborative efforts with ACES and the Demographic Registry. ACES is the Administration for Health Insurers. They work with the insurance companies, and with the Demographic Registry, we get database of live births and deaths. We have collaboration with HIV, HEP, B, and C Surveillance Division. And then lastly, we have collaboration with the SEMI and Gamma Project for HIV services and treatment for pregnant women and infants. And they concentrate on the pregnant women, and Gamma is for the babies. And this concludes my presentation. Thank you very much. Any questions you may address at the question and answer period or to the information provided on the screen.
Thank you, Magda. We're going to move on to our next panel presenter,
Gracias,
Okidiri.
Magda.
If you would please join us on the virtual stage, Okidiri.
Yeah, I'm here.
Perfect.
All right. Good afternoon, everybody. My name is Okuderi, and I'm the Congenital Infection Coordinator for the STI program, the BHHS Bureau of the New York City Department of Health and Mental Hygiene. And for now, I coordinate the congenital syphilis infection. And are you hearing me? Are you hearing me?
Yes,
Okay.
you're good.
Yeah, okay. So, and also neonatal herpes, and currently I am also coordinating the Mpox disease for the city. First slide, please. Okay. Now, if you look at this slide, you will find out a bit NYC background, that you can see that we have a high burden of STIs with over 2,000 primary and secondary syphilis cases for the past 3 years. Next slide. All right, this slide is a lot going on this slide. And I will want to orient you as regards this slide. If you look at the green bars, they represent the number of congenital syphilis cases from 2010 to 2022, sorry. The left axis corresponds to these bars. Again, the blue line represents the rate of primary and secondary syphilis per 100,000 among people who were reported as females. So the line also uses the right axis. And also you can see that in 2010, both congenital syphilis cases and female cases were very low. As the rate of primary and secondary syphilis cases among women increased, so also we have increased number of congenital syphilis cases. Next slide. So while this was going on, while this increase was going on, so we decided to prioritize our case investigation and partner services. This was born by a team. It was a team, and eventually I was the leader of the team. That was when I was supervising one of our clinics. So when I saw the increase, I decided to just assign a DIS, one particular DIS, to all female cases. And that was how the idea was born. Next slide, please. So it was you will see the prioritization practice in one case investigation and partner services team. It was expanded from my program. It was expanded to all debut, and syphilis investigation among people reported as female only were being streamlined to only one DIS. So only one DIS was now assigned with all female cases in all the clinics. Next slide, please. So, all right, the congenital syphilis prevention investigator name was chosen by SIPS. SIPS is the Case Investigation and Partner Services Unit of our program. So the short-term goals were to increase experience among CPIs in conducting and documenting investigation among females and infants. And again, we also, needed to have greater and timelier referral of pregnant women with syphilis to social workers who we were collaborating with. And then the long-term goals were to improve treatment timeliness and adequacy of treatment. And then also to identify more sex partners and investigate and evaluate and treat them accordingly. And then also another long-term goal was to increase total test screening of pregnant female for syphilis. Next slide, please. So in January 2020, when we were not aware of COVID coming, we had a staff meeting where we introduced the CPI model, and we conducted a survey. We were happy to see that most staff thought that CPI seemed important and made sense. And but we were really gratified also to see that more than half expressed interest in being a CPI. So we also asked staff to identify any barriers to the proposed program. Next slide, please. So we also asked what types of training. No, go back one. Go back one. Okay, all right. So let me talk about this slide. So in this slide, we also asked about the training needs of the folks. And what we got was that some of them wanted more information in syphilis pregnancy and more detailed information on congenital syphilis. They also wanted an interview protocol for congenital syphilis interview. And because investigations among pregnant persons with syphilis are not common, some of our staff felt rusty on the specific protocol for doing congenital syphilis interviews and chart review. So they also wanted to get more information on pregnancy and prenatal care. And additionally, they also wanted to improve on their counseling skills. Some specifically wanted to, training on motivational interview. Next slide. So as we were contemplating on what to do and how to, start the program, NACHO provided an excellent opportunity to fund some specialized trainings and evaluations of the CPI staff model. Next slide, please. So this slide is jam-packed, and so I won't go through the details, but I would like to highlight a few things about it. First of all, the supervisors were given the permission and authority to select the staff that will be the CPI in their clinic. So we allowed the supervisors to do the selection themselves. So, and again, the kickoff meeting was May of 2020. So virtual, it was right in the middle of the first COVID wave. During this meeting, we conducted a pre-implementation survey. So in next slide, please. So here is a list of the first set of trainings provided to the CPIs. the trainings marked with asterisks can be found on the CSTE website. So the CPI social worker training was given by our social worker team and was intended to emphasize the partnership between the teams. So it was focused on the reality that this work could bring up personal issues for the staff, and that social workers could provide support to them as clients. Next slide, please. So in 2021, we conducted a post-implementation survey, and we had a few specialized trainings and evaluations. And we also had to engage an external consulting firm, the Midwife Life Consulting, from March 2021, and we still have the contract with them. So the Midwife Life Consulting, they conducted a lot of trainings for our staff on congenital syphilis and perinatal care. So in the training, they taught more of creative conversations and clinical updates. Also, the part of the training was also motivational interview training, because most of the staff specifically wanted that training. So Midwife Life Consulting, we're still in the contract with them until today. Next slide, please. So if you look at this, you hear the result of the pre and the post implementation surveys that we did. So if you can see in the post implementation column that the staff perceived knowledge, attitudes, and practice improved in most areas that we assessed. Like, for instance, conducting interviews, you see we went from the pre from 84 to 87. And then case definitions for congenital syphilis improved from 76 to 93, and so on and so forth. Next slide, please. So these are some of the results. We also evaluated completeness of important cases variables like estimated due date and the date of first prenatal care visit. Next slide. So you will find out that there was a great improvement, a great increase, 13.3% increase in completeness of estimated due date, and also completeness of first prenatal care improved to 20%, and also completeness of substance use variables also increased by 22%. Next slide. So here are some also other variables that we evaluated. Next slide. So we also saw a great improvement in the timeliness of syphilis investigation. It improved by 15%. And then timeliness of syphilis treatment also improved by 4.6%. And timeliness of partner services interviews improved by 19.5%. Next slide, please. So here are some of the final thoughts, some of the successes that we, kind of achieved or accomplished. The program idea specifically came from staff who were doing the work, which I was part of. And then staff were engaged and they were invited for feedback in a variety of ways, and which, showed some positive signs. And then we also hired an evaluator to help us, evaluate the program. And we have a lot of dedicated staff, and that's why we've been able to improve in all the variables that I mentioned earlier. Then we have challenges because we have planned off-site retreats in person, team building exercises. COVID kind of affected us because COVID required everything to be virtual. And then DICs are still overworked and they are underpaid. It's just too much for New York. We have too much burden of to have higher level of responsibility. And the limitations is that we're not sure that the supervisors are choosing the best of the best to be the CPIs. And we're thinking if we choose a CPIs at random, what, would it be something that will help us or something that will limit us? So that's basically next slide, please. All right, thank you so much for listening. If you have any questions, I have my email address and I have my phone number right there. Thank you.
Great. Thank you, Okadiri. And just a reminder to the group, if you have questions, please use the Q&A box at the bottom of your screen. We'll also be pulling questions out of chat if they inadvertently get in there as well. And we'll do questions and answers at the end of our panel presentation. So now I invite Monica to the virtual stage.
Thank you so much, Erin. Good afternoon, everyone. Monica Versaime from Miami-Dade County. I've been working for the Department of Health for a little more than 6 years. Recently obtained my license as a registered nurse. And since early in my career, I discovered that my passion was helping people on the health field, providing outreach and counseling in the HIV program in Mexico. After moving to the US, I started working in Miami-Dade County Health Department as a disease intervention specialist. Since 2018, I have been working with the pregnant women and earned the reputation as a godmother for these pregnant at risk for STIs and HIV. I will be explaining the best practices and collaboration to address the rise in congenital syphilis and co-infection with HIV in Miami-Dade County. In Miami-Dade County, we have more than 140 disease intervention specialists, DIS, whose primary responsibilities include conducting case investigation, contact tracing, and offering partner services to clients with STIs, their partners, and other at risk. As you know, congenital syphilis infection rates have rapidly increased in the nation. So in 2018, Miami-Dade County decided to implement the specialized roles on congenital syphilis DIS to address these cases. And after a deep analysis, we come up with the idea of providing a comprehensive case management to pregnant women with syphilis, chlamydia, gonorrhea, and HIV from the initial infection through notification to the birth. And 2021, since the incidence of congenital syphilis continue growing, the HIV perinatal team take a particular role and engage closely with mama bears. We call mama bears the patients that are infected with HIV, and providing education, treatment, partner services, and prevention. If the mother has a co-infection, we will see it first by the congenital syphilis team and walk it through education, treatment, and prevention, and then we'll be transitioning later to the HIV perinatal team when finished treatment for the STIs and walk it through the case management with them. The HIV perinatal team as well will monitor baby care through the birth up to 3 months of the baby's age. I'm being referred by my patient as a godmother because as soon as the disclosure of the infection is done, the education and bonding begins. This holistic approach giving me the clients the opportunity to join them as part of their life and have a close relationship with them. Soon we have replicated this role of the identification on all the members of the team and also have been adopted by the HIV perinatal team. As the congenital syphilis team, we are the center of the care for our pregnant clients. We make that connections and maintain that relationship with the pregnant to address wide-ranging medical and personal needs. These include obtaining prescriptions, coordinating clinical and prenatal appointments with providers, and linking them to transportation, housing, food, clothing, or other critical support services through the pregnancy. From the initiation of the project, we focus on the pregnant woman as the support and companion at any time during the pregnancy. We know that the care of every single mother that has a positive test is crucial and involves factors such as race, ethnicity, beliefs, and socioeconomic status. Specific guidance is needed to ensure that the mother and baby are not part of the statistics as a new case of congenital syphilis or perinatal HIV transmission. Remember, a positive test can occur any gestational week of pregnancy, and that's where the challenge begins. What we generally do for our clients. Once the client is either reported by a private provider or through our clinics, the investigation begins. We're contacting or locating the client. Sometimes the challenge is to convince the patient that are homeless or immigrants because of the fear that they have to be reported by DCF or immigration is a constant main priority for us. The main topic is to address at the beginning that with our clients that we don't report to any of these agencies so that way they can trust us. Once the patient is contacted, it is referred to our STD clinic for evaluation and treatment and in cases needed for STIs. On the other hand, if the mother has histories of HIV, is handled directly to the HIV perinatal team for partner services, education, and referral to prenatal care high-risk pregnancy. In the clinic, during the interaction with the client, we gain patient confidence, establish that rapport, trust, and education are the main priorities for us. By putting ourselves in the client's shoes, the client is able to comply with all the indication, understand the illness, sexual partner disclosure, the need for treatment, and mostly to protect the health of the baby. At this point, we ensure that the client gets access to the community resources available and keep track of the client after completing treatment until delivery. Inside of the health department in Miami-Dade, we have an STD clinic that work collaboratively with the family planning program and refugee clinic program, who have been play an important role for us and for our clients, since in the family planning and refugee clinic had implemented a syphilis and HIV test for all women in childbearing age. And in the case of the patient is pregnant with syphilis or HIV, is reported immediately for evaluation and is oriented either to the congenital syphilis team or HIV perinatal team for case management. If during the engagement is necessary, the linker for prenatal care or other complementary service that are essential to continue in the circle of care. For example, in case a patient doesn't have insurance, we connect them to our family planning clinic, agencies, or nonprofit organization that can help with the application for the Medicaid. When the patient are homeless or has a substance abuse issue, we link them to shelter, rehab, or mental health services organization. When the pregnant client is referred to a prenatal care due to high risk for HIV diagnosis, the services are received by the University of Miami, which is the only and main provider that get the complete and integrated service all in-house for these women. So we have this advantage with them. Basing our intervention has been seen a decrease from 31 congenital syphilis cases in 2017 to 19 cases in 2021. That represent a 38.7% decrease for the Miami-Dade County. The project is in continual application of strategies. Day by day, we implement new ideas that can help us to achieve our goal and sustain our numbers. Of course, we have challenges. STIs and HIV can occur in any week of the pregnancy and could be a barrier at the third trimester for a mom that just get test positive and the time delivery is around the corner. As well, we work with clients that have substance abuse or homelessness status. That's been difficult to achieve sometimes treatment or referrals for them. Lately, we partnered with a needle exchange program that has been helping us to reach and get tested women in childbearing age, also to increase awareness and also helping us to get in touch with homeless and substance abuse women in the community. It's well known that homeless, substance abuse, and immigrant mother use hospitals as an emergency room as a prenatal care to check on the baby. In 2021, we received a grant from NACHO that was implemented in screening for syphilis and HIV to all women in childbearing age every time that they attend the ER in the largest community hospitals in Miami-Dade. The main purpose of this project is to create the trust and relationship with the client, as well to ensure that the partner's elicitation is successful. This will be ensuring a high probability that the mother not being part of the statistics. We look for sustainability to maintain the program to avoid an increase in our congenital syphilis cases and continue with zero status statistic for HIV babies. We also look for partnership, increase the network to be able to serve more women in the community. And lastly, we would like to encourage if more programs replicate this work and see similar improvements, identifying effective intervention to prevent congenital syphilis and HIV perinatal transmissions. Thank you.
Thank you, Monica. We appreciate it. We're now going to move to question and answers, and I have a few excuse me, we have a few in the Q&A box. And just a reminder to our audience, if you'll use that Q&A box, we have way too many folks on this meeting for hand raising or unmuting. So please use the Q&A box or the chat. And my first question that I have to ask is for Okadiri in New York City. Would the CIPS specific DIS only take on female cases, or do they also take on other DIS investigations when there might be periods of lower female reported cases?
All right, thank you. Thank you so much for that question. 8.6 million people live in New York, and we are never short of female patients. So the CPIs, they specifically deal with females, females of child-bearing age, and then also females who are, above childbearing ages, and all what they do specifically is just to deal with them. There's no other syphilis case is assigned to the CPI, and for every clinic we have one CPI, and in every clinic we have like 6, 7, sometimes 8 DISs. And one is selected to be the CPI, just dealing with female cases only, including pregnant females.
Great, thank you. Next question is for Magda in Puerto Rico. How was the directory of OBGYN physicians created? And once that directory was created, how was outreach performed, and who did that outreach?
Sí, gracias por la pregunta. El directorio.
The directory, I already had a database because of the work where I was previously, where I also worked with the perinatal area of congenital defects for the Department of Health. When the pandemic for Zika came around, we started to do that work together with other colleagues, contacting all providers. We did work it again here. It was updated because there were providers that had emigrated, providers who had retired or who had passed away. So we updated it with information from new providers. The other question was,
Creo que me habían hecho dos preguntas, la de los
Oh, sorry.
I
proveedores.
think I was asked 2 questions. What was the other?
Yes, the other part of the question was, once the directory was created, how was outreach performed and who did that outreach? And the question was for both public health and hospitals, so public health and private providers.
Pues para esto tuve la colaboración
For
de
this, I had the collaboration of personnel from the division, from the Education and Communication Division, who made all the phone calls together with each one of the health providers. So we spent some time on that, and we would update the information and notify them that they would be receiving an email with information and reference materials such as the guides for screening and treatment, the CDC recommendations and public policy on HIV. And then we created that directory in Outlook and sent it to all the providers. Even so, we had some returned emails, and we contacted those providers again to see if there was an error, and then we resent the information. And then whenever there's some type of investigation reported or got a pregnant woman, we re-verify with the provider to see if he's already or she already there, and if not, then we update it. I also want to point out that for the continuing education activities in this section, that where we do the conference, we send the invitation to all providers for them to participate also.
Great, thank you, Magda. And our next question is back to New York City, Okadiri. Do you have any analysis, or have you done any analysis of the success that can be shared by the type of treatment used? Doxy, 14 days or 28 days, or Bicillin, how many doses, etc. The audience would like to learn about any successes related to the type of medication used.
Okay, basically for pregnant females, we treat with Bicillin for pregnant females, basically. Well, I don't really have the statistics, but that can be, presented after today. And then for Doxy, we rarely use Doxy for to treat females. Even when they have allergy for penicillin, we send them to be desensitized, and then to the hospital to be desensitized, and then we go ahead and treat them with Bicillin. So 95.5% of the times we treat with the females with Bicillin.
Great, thank you, Okadiri. We're gonna head to Miami-Dade County for some questions for Monica. Monica, who is eligible for the refugee clinic, and do clients move to the STD clinic if they are positive for an STI in the refugee clinic?
Yes, well, it's well known that Miami-Dade is one of the largest cities that would receive refugees. We receive refugees for all countries. We lately partnered with them. We would find that most of the women that are presented for refugee services are from Venezuela, Colombia, Nicaragua, Haiti, and come already with an infection, a history of syphilis or history of HIV. And this program helped them to get a status in the country. So basically, they get tested for also tuberculosis, all STDs, and a referral to prenatal care in case they need it. So we partner with them. We target all pregnant women, and we wait for the results. The results are reported to me, and we analyze the case. In case the person just need referral for prenatal care, we do that work. in case the person tests positive for any STI or is HIV, is referred to our STD clinic. We complete treatment, and then we analyze what are the options for this mom in terms of prenatal care. And we refer out to the OBGYN programs that have available. But yeah, it was successful that partnered with refugees and family planning services for this testing.
And a quick follow-up question to that, does everyone using the refugee clinic get tested for STIs?
Yes, yes, everyone is part of the panel, as well as tuberculosis and hepatitis.
And while you're unmuted, Monica, I have another question for you. If you could quickly elaborate on some of the strategies you use to engage hard-to-reach congenital syphilis cases that are fearful of the medical system and don't often access prenatal care and only present to the ER.
Yeah, most of these mothers either have a problem with substance abuse or homelessness, or either also are raped mothers that doesn't fall in the category that have a prenatal care or insurance. So basically, my first attempt is to contact them directly, going to the house, and as a mother, as a woman, convincing them that we are them to help them. Sometimes the first approach is just, you need treatment, you need to see on baby, you need your baby is at risk for, even you can lose your baby if you don't get the treatment. You can not get pregnant again if you don't get treatment for chlamydia. So explain the meaning of the disease and the consequences that will have later on if they don't receive treatment, as well as offer them that companion, that understanding of that they are not alone. I'm a woman as well, I'm a mom as well, expressing their concern, not just as a healthcare provider, as a woman, that I'm there for just for the health and for the well-being of the mother and the baby. So basically, sometimes he's trying to convince it to trust us, to trust on the system, to trust that medicine, to trust that a simple evaluation can change the life of the baby and the mother, and going on at the term, because sometimes, yes, is a no at the beginning, but I always let them go at their pace. It's at your pace, it's not at mine. I will be ready when you're ready. I will be available when you are available. So that's the way that we engage our patients, and we create that bond.
Thank you, Monica. I have time for just one more quick question, and I want to ask all the panelists. Are there any congenital syphilis or perinatal HIV case management manuals, resources, or tools that you have found beneficial to your work, or that you would like to share with our audience?
Well, I will say following the STD, CDC STD guidelines as well, with not just patients, when talking to the providers, meeting the also the status of each state, like the guidelines, the status, the laws, and use it as a weapon to come on board all the providers that sometimes doesn't know about STIs, doesn't know about syphilis, doesn't know about the repercussions on the baby, I usually knowing well also the testing, the recommendations, the different confirmatory tests, the different options that they can do it, how they can do it, talking more about sex practices, because sometimes doctors or healthcare providers are just relying on this. A pregnant woman is just having one partner, which is sometimes it's not, or coming from another country, partner is in the country that the person left, and sometimes not. We will also find refugees that in the way of coming to the United States have been raped, have been even though have to interchange sex for money or for living or even just to pass the border. So is talking to your patient is a really good advice and advice to the providers that are going to participate on the care of this patient. I believe that is the key and success for these patients.
Great. Thank you, Monica. And now I want to turn the time over to Rebecca to really quickly talk about this amazing compendium where we can all share resources and learn from each other.
Thank you, Erin. So folks may be wondering why we held this webinar all of a sudden. And the reason is that NACCHO created a congenital syphilis compendium a few years ago where we've been housing interventions that folks can submit themselves. And then it provides a resource for individuals to be able to search to see if there are interventions for congenital syphilis that might align with what they're thinking about doing. And they can reach out to the person that submitted it, ask them questions about how the implementation went. And excitingly enough, NCSD and NASTAD are going to be joining us in the effort to keep this compendium updated and getting folks submitting their information. And we're expanding it to include prenatal HIV interventions. So if we can go to the next slide, the goal is really just to create some more opportunities for peer-to-peer interaction and support and education. So you'll go to this website. I'm going to put it in the chat. If I still have it. Oh, nope. Now it's a question that I asked from a webinar participant. Let me pull it back up. The site is on NACCHO's website all over the place, and we've done a ton of promotion through NASTAD, NACCHO, and NCSD in recent weeks. But I'm also going to pull up the link eventually. My internet is kind of slow right now. Okay, here's the link. So the goal is to really just, and Sonia put it in the chat too. Now it's going to be in there twice. The goal is for folks who have participated in this webinar to add their interventions that they've tried, whether or not they've been evaluated. And you can share, we tried this and we don't think it was very successful. That's as helpful as anything else. And you just go on here, you'll see my thing moved. It says STD registry now. But if you look below that, the congenital syphilis compendium, it will now be updated to say congenital syphilis and perinatal HIV compendium. And then next slide. You just click on that and you'll fill this out. Again, the congenital syphilis, these are old slides. So congenital syphilis compendium will become congenital syphilis and perinatal HIV syphilis. I'm sorry, perinatal HIV compendium. And you fill out your contact information here, and it will allow you to submit your interventions. You can review the compendium without signing in. It's totally free and available for folks to look at. So if you're thinking, I would like to do an additional DIS activity, you can search around and see. There's a lot of options for how you can narrow down what's in the compendium so that you're able to find interventions that are relevant to what you're thinking about doing. So I really encourage folks to submit interventions and have some time set aside to look through the compendium and see what your peers are doing across the country. That's it.
Thank you, Rebecca. And that concludes our webinar. All of the national membership organizations' contact information is on this slide. We will be sharing the recording, and feel free to reach out to any panelists if your questions were not answered in this presentation. And thank you, everyone.